That requires developing skills, developing negotiating abilities with the medical neighbors, and tracking to see how quickly you're getting your consult reports back, to see whether there are labs that you've ordered that are outstanding. And then based on that, to make your decisions about the medical neighbors that you'll continue to use. One of the most important outputs of care coordination is the ability to really know what medications your patients are on that other providers have prescribed, and to be able to reconcile medications from when the patient was in the hospital, from when the patient saw a specialist. One of our advisors, when I worked at NCQA, said that the point at which the patient is discharged from the hospital is the most dangerous point in the healthcare system. So much can go wrong. And right now, Medicare patients experience a 20% readmission rate within 30 days. The system is looking for reduced readmissions, reduced admissions, fewer medication errors. We actually work with a large system in Georgia that, as a result of really very actively coordinating care, is now achieving a 1% readmission rate. So these changes are not impossible. And then quality measurement is the last major concept that we'll talk about today. But this is very much a part of the patient-centered medical home, actually being able to access your own data, use it to continually improve care, use it to achieve recognition, and ultimately to obtain rewards. So once we've gotten practices through that very difficult transformation stage, gotten them to really understand the difference and what they need to do to be a patient-centered medical home, we start talking about rewards and what that means, and how the system, how their payers or employers or the public sector is going to reward them. And this is, again, a new set of vocabulary words. First and foremost is total cost per patient. We work with a lot of practices that have never actually seen their average total cost per patient, which means the total cost that the patients within their practice incur for all of the services that they use. Generally, the amount that is paid to primary care is about 6% of the total cost. And yet that other 94%, we believe is, if not controlled, heavily influenced by primary care. And that's part of what we're looking for the patient-centered medical home to do. And so we talk about total cost and what does that really look like. And then we also talk about all these other terms and bring them into the vocabulary and come out at the end with value. What's the value to the system of the patient-centered medical home? How does it improve quality? How does it control costs? So here's what the people who pay for health care, the people who worry a lot about Medicare and really want to see savings, here's what we really want to see happen. So I just talked about the total cost of care. This is actual data on total cost of care from 2009, and you can see that it's almost up to $6,000 per person. Here's that very small part that's primary care. We'd like to see that grow. We expect that the patient-centered medical home will actually, because of delivering more comprehensive care, will deliver more primary care services, and their proportion of total costs will grow. We also think probably medications, the cost of drugs will grow with better chronic care and better adherence to medications. But we expect to see the other parts of the total cost band to get smaller. So hospitalization, other physician services, other medical services, the expectation is those will shrink, and that will produce savings. And while that savings doesn't look very big, that's actually a lot. That's, if you're talking about 5%, 6% savings, that's real money. That savings is actually about the same size as the total payment for primary care. So where do we think the savings can come from? Well, it can come from the areas that we talked about when the patient-centered medical home is successful. And I need my slide advanced. Next slide, please. There we go. Okay, so these are those impacts from 4 of the slides we looked at, 4 of the functions of the patient-centered medical home. We think that these savings can come from better access, fewer ER visits due to the patient-centered medical home, making more access available, from patient engagement, which achieves better controlled chronic conditions, just much more concentration on those patients who need extra help, who have chronic conditions. And then, as a result of better coordination, reduced hospital admissions and fewer medication errors. All of these impacts are equal to improved quality for patients, improved happiness for patients who don't wind up in the emergency room when they shouldn't. And ultimately, we know that there are many benefits for the people who work in the patient-centered medical home itself. We're focusing on costs today, and I would like to turn it over to Guy D'Andrea to talk about how we develop payment methodologies to capitalize on the benefits of the patient-centered medical home.
Thank you,
Guy?
Linda. Thanks, Linda. So I'm going to talk a little bit about some of the payment models and the issues and challenges that we see as we look at patient-centered medical home payment systems around the country. And just to stress the importance, again, of payment and this link between payment and performance, all of the improvements that Linda has described in her slides are improvements that require energy and attention, and sometimes resources like installing an EHR or hiring a new staff person to do care coordination. And so these improvements really are not feasible to achieve, and certainly not feasible to sustain without some meaningful payment model to support them. And so that's what I'll talk about this afternoon. So to start, this slide is similar to the slide that Linda was just sharing with you. And it really illustrates how these savings that occur not through a reduction in primary care, but through a reduction in some of the other medical services that occur when we have more primary care and better primary care. It's the savings that result that are then used potentially to fund payment models that can support and sustain the patient-centered medical home. And those payments can take a number of different forms: increased fee schedules, care coordination fees, shared savings, but ultimately they're all derived from this concept that the PCMH can actually generate savings in the system. So starting with that as a sort of an overarching goal, when we think about designing a PCMH payment system, we have to keep a number of more specific goals in mind. First and foremost, and I think we should always remind ourselves that the goal is to improve care for patients, to improve their outcomes, and improve their experience in the healthcare system. After all, that's what we mean when we talk about patient-centered care. So we need to create payment models that encourage engagement of patients and encourage quality services that deliver the right services at the right time to patients. We need to think about how to sustain transformation, how to promote improvement in care delivery. And these four areas are the areas that Linda described. And again, none of these happen without resources. And so we have to try to direct resources to those specific areas through enhanced payment models. We have to keep an eye on savings. Again, as I mentioned on the previous slide, it's only through generating savings that we can actually sustain additional payments to primary care practices. Healthcare is already, as we know, too expensive. It takes up a large chunk of our national resources, and there's very little appetite or willingness to add to that number. So any new payments that flow to primary care practices have to be funded and sustained through savings. And then two other goals regarding PCMH payment that we always have to keep in mind is that these systems have to be practical. Right? We need to come up with ways to actually implement these systems. We can't just design these in theory. We actually have to put them on the ground. And as part of that, we also have to make them reasonably simple. They should be simple enough that providers understand what they need to do to be successful. They should be simple enough that a health plan can administer the new payments without too much administrative burden. And they should just be simple also for patients so that patients can understand why these systems are to their advantage. And so what we see when we look around the country at different PCMH payment models is typically PCMH payment retains fee-for-service as the core revenue to the primary care practice. So in a typical PCMH implementation, it's certainly true here in Maryland where we've built the state pilot, PCMHs would continue to bill for their services much as they have done before, and they might even see an increase in their fee-for-service revenue because they're providing more services to their patients. And in some cases, health plans have chosen to increase the fee-for-service payment schedule for primary care practices that have engaged in patient-centered care. We here at Discern actually don't recommend increasing the fee-for-service payment schedules as part of the PCMH payment model, because what that does is it puts more emphasis then on a payment system that we know ultimately is probably not the best. As I described earlier, we know that fee-for-service payment promotes fragmentation, it's indifferent to outcomes. So generally we want to avoid putting more eggs in that basket and look towards implementing other payment components that actually drive real improvement in the system. And that's where the fixed payment comes in and the incentive payments come in. So on top of fee-for-service, we would add a fixed payment component. This would be a set amount of dollars, typically expressed on a per member per month basis, that a provider would receive. And that would support some of the ongoing efforts that they need to transform and sustain transformed healthcare. And then on the back end, we would build in some incentive payment component. That is typically focused on shared savings, although it might also be connected to performance on quality measures or clinical process measures. But these three components together, and I'll talk more about the fixed payment and the incentive payments in the remainder of my slides, these three components together really form the core architecture of a PCMH payment system.